I suppose really this is just to show you some pretty pictures of Islington, first of all, on the first page. We are an inner city, very diverse population, fifth most deprived nationally. But actually, interestingly, when you look at the demographic, a really very young population with a bulge sort of within the 35 to 45 age group, but also with a significant problem with long-term conditions, but particularly linked to the issues around deprivation. The long-term conditions are occurring much older and much younger in our population. So we really have had to think about sort of not just thinking about the concept of frail elderly, but really thinking about, again, a whole life course approach. And I suppose particularly our pioneer is very much focused from childhood through to adulthood, recognizing that children also and young people value better integrated care. And a little bit around the story of Islington, I suppose, you know, we do come from a history of joint collaborative working, which goes back over a long period of time. So 10 years of pooled budgets, particularly across health and social care, looking to support carers, learning disabilities, mental health. So I suppose it's on the basis of that and quite a long history of working with the voluntary sector, and the fact that over the last, in 2009, the establishment of the Whittington ICO, which is an integrated care organisation combining community services with local authority social care element, has really, I suppose, provided the springboard for us to really begin to have these conversations around integrated care, but particularly how we can collaborate to develop a different workforce vision to map to the work that we're doing. And in essence, the model that we're trying to develop is really to develop better person-centred coordinated care, very much along the lines identified by National Voices in the information that they published last year. But for us, it really is with a strong focus on prevention, developing coordinated person-centred care, and working on the co-creating health model, which is really around using motivational approach to support individuals to identify goals and then to support the personalised approach to sort of achieve those goals. And so for us, that's a very key element around the clinical work that we're doing, and supporting that with quite advanced thinking on the development of personal health budgets. So particularly now we already have a number of patients, not only continuing care patients, but patients with long-term conditions, particularly mental health related problems, chronic pain, etc., who are beginning to experiment with receipt of personal health budgets to really support that personalisation agenda. In tandem with our new model of care, I've heard most of us have been talking about the development of our sort of locality offer, which we all call different things, but by different names, but it's really how we can begin to affect the development of a community team, which is holistic and whole system, that can support people in a better way in the community. And I suppose really thinking around how we can bring together issues around long-term conditions, but particularly the sort of parity of esteem around supporting patients with mental health problems, because certainly for us the coexistence of mental health problems and long-term conditions is a very real problem. So I suppose that's enough really around our model of care, and I suppose it's around how we have gone about developing our workforce. And I suppose this really came out of, you know, conversations and engagement exercises that we've done over the last few years to really better understand what our staff want and what our service users are experiencing of care. And certainly we've had a lot of feedback from GPs, for example, recruitment problems. We're facing a 16% retirement, I think particularly in Islington. We have a 30 to 40% cohort of salaried doctors. So it's really how we listen to what people are saying. We've performed recent research or sort of feedback looking at our community nursing services, because there's a lot of feedback that it wasn't fit for purpose. And certainly the feedback that we've received has revealed problems around recruitment and retention of nursing staff, particularly in London, problems with obtaining affordable housing. So there's really been a sort of groundswell of voice that we've garnered in terms of really being able to understand what it is we're dealing with. And I suppose Sanjiv and I met because Sanjiv, in his capacity working for health education North Central and East London, was very keen to develop a new system of delivering education within the community. And this was really around supporting the development of collaborative, meaningful conversations between providers and commissioners to really begin to understand what was happening at the coalface, to enable that process of organic development to really inform workforce development going forward. Sanjiv, I don't know if you want to say a little bit about the particular ethos, I suppose, the aspiration.
Yes, happy to do so. I mean, most of this arose out of a recognition that with the demise of primary care trusts and strategic health authorities, we suddenly found a vacuum in local communities around coordination and organisation of education, training and workforce development. And at the same time, we also realised that actually relationships between professions and across professional and organisational boundaries was stilted. But to add to the compound to the problems was the issue that we didn't actually know what our workforce looked like in the primary and community sector, and we didn't also know what kinds of education training needs they had, nor what kinds of future roles that they may need to be empowered to undertake. So with that in mind, we started thinking about how we could empower local communities to come together, and particularly thinking about educational networks as being a way forward of bringing together different professional groups from different parts of the system, including community, primary, acute and social, to come together around the table and talk collectively about the development of the workforce, and have the CCG engaged in defining what kind of their commissioning intentions were, so that those could feed into the development or thinking about the development of the workforce. So that's why we're sort of developing a model based around communities and local communities of educationalists, and with links into HEIs. Sorry?
So I just lost you for a minute there. Could you just repeat that?
What I said was that what we've tried to do is to engage local communities of educators to work with our clinical commissioners and our local higher education institutions to support the linking up workforce planning with education training and clinical services, and the way clinical services are moving. I think I'll stop at that stage and ask if anything else, Joe, you think we ought to add.
Yeah, so I suppose that from the experience that we've had so far, I suppose, of trying to develop our sub-locality community-based structure, there have been some real themes that have emerged, which I think have really managed to, I suppose, identify the work streams that we really feel are imperative in terms of getting the foundations of meaningful integrated care, and how we develop the education initiatives to actually support that. And I suppose for us, it chimes with what's already been said. I think there's a lot around really supporting our staff to develop that common vision and those values, because actually people are in very different places in their understanding of what the locality offer is, what the key elements of education are, what they can expect from their colleagues. There's also, as I mentioned previously, something about having the system leaders signed up to the same vision, but really making sure that that vision is held and worked, is held as an absolute goal and vision by other members of staff. And certainly we've tried to go out to our stakeholders and talk about how we should develop our locality offer. And the real feedback has been, we actually really need to do this in an organic and iterative way, and really listen to what our stakeholders are saying and what they perceive their educational needs to be. And I think the other very important thing is around developing a common language. So when we're trying to integrate organisations and integrate care around individuals, it's so important that we really understand what we're all talking about. So that is actually, you know, another very important key piece of work. So I suppose for us there are some must-dos around really, I suppose, systematically enabling that cross-fertilisation of skills across different disciplines so that we all know how to deliver a care plan, so we all know something about a motivational approach, how to have person-centred conversations. But it is really more about, I suppose, supporting our staff to feel really engaged and to be able to really understand the vision of the whole. There is a slide in the slide deck which I won't talk too much about now, but it does talk about a very important example where it's the learning from experience, so slide 8, where we went out to our staff to sort of do a significant piece of service redesign around a community rehabilitation and reablement service. And this was really given as a sort of offering to the staff that worked in that team to really begin to do an iterative piece of work as to how that service should be improved. And I think through a process of bottom-up continuous quality improvement, they actually completely redeveloped the service. It was a small-scale pilot, which eventually it also incorporated community nursing and a mental health element. And unfortunately, because it was a pilot, it was quite short-lived. But in terms of the real engagement that we received from staff and the real passion and that going the extra mile was absolutely remarkable. And when unfortunately the pilot was stopped, because obviously it was a pilot and we needed to evaluate, there was a real, I suppose, groundswell, which was to say, no, we must continue with this. And so I suppose for us it's very important, this is a very important message, which is really around being able to devolve our leadership to our staff, to enable them to really feel engaged, to make things better for patients. So I suppose I'll stop there because I'm mindful of time and we still have to take questions.
Thank you very much. Francis, some questions for Sanjiv and Joe.
And so then there was me, isn't it, really? And thank you both very much indeed. The reassuring thing is that we're all trying to do the same things, isn't it? But equally extremely helpful to hear how you've gone about it. A couple of things I wanted to pick up, particularly around parity of esteem, because it is the new buzzword, and it's something I personally feel passionately about. But you know, you've talked a lot about values and about culture and about leadership. So it's kind of, what does that really mean in terms of the emphasis that people are putting on mental health as well as physical health? How's that translating into the experience for people and the skills that the workforce need to deliver that?
So very specifically, so we have mental health very much at key partners at every level of organisational development and structure, and we, in terms of trying to begin to deliver a much more integrated multidisciplinary approach around mental health education, we have begun to develop programs whereby we are trying to upskill particularly practice nurses and community nurses in mental health related issues. We also have some new pilots working particularly around personality disorders. So psychologists who are now working in a sort of iterative way, attending multidisciplinary teams in practices, talking about supporting teams to manage more complex patients, particularly with personality disorders. So bringing to the fore the complex mental health related problems that form part of, you know, long-term condition management. So it's about starting with small areas and actually building on that, and I suppose making sure that the education is disseminated in a multidisciplinary way, because mental health is certainly an opportunity for that.
Okay, thank you. And one for Sanjiv, I think, really fascinating in terms of, you know, how you've picked up the the kind of auditing, what does it look like now, who have we got, what are the gaps, and all the rest of it. What's the input from the Academic Health Science Network, from Health Education England at every different level, or is this a kind of united democracy of Islington? Is the kind of, how insular is this, and how widespread and how externally looking is it?
I think there's a recognition that actually the data available around the primary and community workforce is limited, and that inhibits making sensible plans. And so I think there is work going on at both national and local level to improve the quality of the data and the collation of the data. So the way I see it working is there's going to be a top-down approach run out of Health Education England through CCGs, I suspect, and local area teams that seeks to try and better understand the current workforce. Then there is a bottom-up approach that needs to happen as well, which is much more focused around the local context, not just in Islington, but really in all the boroughs across North Central and East London, where we've got to understand not only what is the current workforce, but what should it look like as we go forward. And it's about bringing the higher order level data and the lower level order data together, so that we begin to have a good sense of what is required for not just local communities, but also more broadly across a bigger geography.
Okay, helpful, thank you.
I guess if I can add one thing, it's really, you sort of touched on generic skills and capabilities. What are the challenges of establishing a set of generic skills and capabilities across an entire workforce when the history of the entire workforce is towards sort of less integration and more specialization at every turn? And how far have you got in identifying what those generic skills and capabilities are and how we might deliver them?
So I think certainly mapping to the work that we're doing, some of the generic skills may be around sort of really understanding the meaning of care coordination, really understanding how to have meaningful person-centered conversations. If we're really trying to understand what person-centered outcomes are, there is something about going back to basics and actually looking at how to have meaningful conversations with individuals. There is also something about the motivational approach and goal setting, which again is a generic skill which can be carried forward from GPs through to healthcare navigators. It's around really having that systematic approach. And there is also something about the values of an organisation, the way we communicate compassion, that sort of the method of communication which delivers that. So I think we've identified some of the key themes which are very sort of strategic, I suppose. We have the basis of multidisciplinary learning opportunities already in place, aligned to the co-creating health model of delivering that, of delivering the motivational approach. But I suppose the difficulty is how you begin to, create the dialogue with staff within different organisations to really support them in understanding that this is a meaningful and important thing to be doing. And I think that's the bottom-up approach. That's where it's going to take a little bit more time, and that's where there does need to be the sort of distributed leadership. It can't be top-down. It has to be understood from the bottom up, I suppose. And for us, I think the importance there is about really involving our patients and service users in that educational process, because there's no one that's going to tell a GP more eloquently about what they need than a patient. So that's another very key message. I think it's the co-production message.
Thank you. So just to push you on that, how much experience have you got of involving patients and carers in the initial education and the continuing education of healthcare professionals?
So certainly we have a number of experts by experience who work within the context of the sort of expert patient program, and are also very much involved in the teaching of the motivational approach, for example, to healthcare professionals. In terms of really systematically and strategically embedding patient voice into the work that we're taking forward, we have a body called the Making It Real Board. And the Making It Real Board is a collaboration of service users, many of whom are in receipt of personal health budgets, and who form peer networks. And so for us, that is the beginning of a translation of real patient voice, service user voice, into how we can begin to develop our educational processes and initiatives going forward.
Can I just add something to that, if I may?
Yes, please do.
It's that one of the issues that I keep seeing again and again is about the fact that actually the agenda for integration isn't going to really succeed without the development of relationships between healthcare professionals, health and social care professionals, but anyone looking after others, and between patients and healthcare professionals, and that the need to actually do very basic things like support, respect for patients, caring for each other, supporting each other is a sort of fundamental part of the journey. We talk about parity of esteem in relation to physical and mental health. Actually, we should talk about parity of esteem between different types of healthcare worker, because that, I think, is a fundamental challenge that we face within our system. And if we can begin to get to the bottom of that, we can begin to value all the different professional groups and the different types of worker that are currently working in the system to provide care.
Thank you, Sanjiv. I think that's very well put. I was struck earlier when I think Joe said that most of the workforce have worked in the hospital, but a much smaller proportion have worked in the community. And it may be in 20 years' time the opposite is true. And actually, that part of that process, that shift in the workforce, will change some of those relationships between different roles and different disciplines and professions within the workforce. I think from the work that we've seen in Lambeth, they have worked very hard to overcome some of those differences and taken a storytelling approach to try and change some of those attitudes and values, using powerful stories of patients' voices and experiences, but also frontline staff as well, to try and create a different narrative around how different, in this case, how different parts of the mental health workforce will work together in the future. I'm conscious that we are approaching the end of our session. I want to thank Joe and Sanjiv. Francis, is there anything that you want to say before we move on to if you have anything you want to say to Joe and Sanjiv before we move on?
No, other than thank you, and now I know where you are, we can talk again.
Absolutely.
Excellent. Okay, thank you both. So if we move to the final bit of our agenda, Frank has shared with us something on his screen, which are some questions that have come in from our audience while we have been talking. And we've got three headings really, one around integrated team, one on staff engagement, and one on predicting future need. And Joe and Sanjiv, you sort of touched on this in your presentation. I was wondering if we could start there. In particular, I'm concerned about planning for future need. Are sites mapping the workforce that they will need in the future, both in terms of demand and capacity? Is there anything you can add to this question?
If I may make some comments about that. Yes, one of the things that I've explicitly tried to encourage is getting our educational networks to start mapping the current workforce, their current needs, and potentially asking our educational network to think about what the future might look like. We've also done a little bit of work within the LETB, trying to sort of develop a strategy for the development of the workforce, particularly the primary care workforce at this stage. And we're trying to bring different bits of that work together to try and develop a composite picture. But again, using both the bottom-up approach through our educational networks, but also using the top-down approach through sort of workforce planning done at sort of LETB or Health Education England level.
Thank you, Sanjiv. I wanted just to move on to a question about integrated teams. Got 3 questions there. I think the one I want to kind of combine the second one and the third one. Frank, if you could just hold your cursor still for a second, it's slightly affecting our vision. Oh, there's another one appeared. That is amazing. The technology is always impressed. Anyway, we've talked about a life course approach, but the last question really is sort of what health and care professionals are needed in different integrated teams. I want to know how that might change over the life course. So do we need very different mix of people for different stages in life? I don't know does anyone want to have a go at that question?
Me.
Go.
The answer is yes, but actually I'd rather talk about skills than necessarily professionals, because if we continue to say a GP looks like this, a community nurse looks like that, then we'll miss some of the opportunity. So it's what skills and how do we have access to a different range of skills to support people at different times, I think is much more powerful, really. So it's people using a skills-based approach, and I really like some of the stuff Joe was talking about in terms of kind of motivational approach. It's also making sure that we identify the person who is best able to support individuals and their families around different issues, and sometimes that will be a very technical expertise, but sometimes it won't be. And there was a discussion about diabetes. Some of that is very technical, but a lot of it is helping people to manage their own care and keeping the confidence in how they're doing.
Yes, and I think a strong focus on individual well-being. So I suppose, and thinking about skills, it's not just skills within our conventional workforce. We must always be mindful to think about particularly the voluntary sector and the absolute wealth of opportunity and resource that that the voluntary sector provides, both in terms of the volunteer cohort, but also, as I mentioned previously, sort of experts by experience. So it's really about thinking how we can also systematically extend the offer of education and support and align the work that's happening within the voluntary sector to the very important work that we're trying to do.
Can I add that actually it will increasingly be teams that deliver care in such a way that actually we don't lose anyone through the segmentation of the population in the way we're talking about it. And that's really quite important, that actually populations and communities will receive their care through teams that may be virtual or physical, but nonetheless it will be teams that take responsibility for the care of people.
And so I'd be very interested to see what work Pioneer Sites have done in mapping the skills and capabilities over the life course, and what work has been done around how they change for patients at different stages. So I just want to touch on the last question, which has come from Wayne, who is in Worcestershire, and he says workforce issues are encapsulated in part by organisational development plans. I wonder what stages Pioneer Sites are at, and whether we could share plans and strategies between sites. And we did touch earlier on a sort of single OD and workforce plan across multiple organisations. I just wonder whether or not, let's go to Joe and Sanjiv with that one first.
If I may start, I mean, I think that one of the things that I've picked up as I've been going through this journey is that actually sometimes organisations become a barrier to effective integration, and the way around it is actually to encourage the development of relationships rather than try and think too hard about sort of organisational integration. And And by keeping the patient at the center of the focus, one can get around the sort of the challenges of trying to create organizationally synchronized OD plans, and that actually where they have emerged organically, it has been very successful. I think Islington's a good example of that. But actually, beyond the geography, I've seen that happen as well, where there are huge challenges around trying to create organizational integration. Sometimes you can actually get great success by actually encouraging those relationships to form organically, and particularly around areas of need and for people in particular situations.
So I would certainly second that. I mean, I think it's, you know, there are so many themes that have come through from the conversations that we've had this evening. I think it would be very difficult to lift and shift a strategy from one area to another. I think the important message would be that there are clearly there's some narrative that's been learned from many sites, and I think that the theme around, you know, having these meaningful conversations and really listening to what we're being told, particularly by our workforce and by our service users, and building those relationships is really the key.
Fantastic. Francis, would you like the last word on this?
Wayne is the delivery support manager from NHSIQ that is working with us and with Waltham Forest. So we're happy to share everything, but I do echo Joe's comments that it's useful, but you can't necessarily assume that a one-size-fits-all. We're all starting from slightly different places, but equally we're very keen to learn if somebody else has got something cracked.
Indeed.
Fantastic. Okay, that's great. I think we're going to close now. Thank you to everyone. Thank you to our presenters. Thank you to Joe, to Sanjiv, to Francis. Thanks to Bob, who's gone off to complete his duties at the local NHS Olympics.